Hello and welcome to the channel. Europe is currently and will be for the next 4 weeks in the throes of football madness, soccer madness for the Americans amongst us. Yes, Euro 2024 is upon us, and now suddenly certain members of the family are nowhere to be seen anymore. If you are a football widow or widower, or your teenage son will be absent from home for the foreseeable future, or you are in a nursing home and you just know that you won't see your football enthusiast son or daughter for the next 4 weeks, I sympathize. I feel you. Just to declare my allegiances, I am with England and Switzerland. And family connections oblige me to also give my support to Italy. Let's just leave it at that. The football, of course, is all about scores. Even those of us who don't care too much about football still want to know the score. That's something football has in common with medicine. I don't know about you, but in the course of my education in medicine and subsequently through my practice of medicine, I have noticed a strange trend. Well, maybe it's not so strange given the context, but it's peculiar nonetheless. The trend is the emergence of scores. Yes, scores of scores. Nowadays in medicine, we have scores for everything. Cardiology, for example, is full of scores. I grew up on them things. If you go to a cardiologist with chest pains on walking up a hill that sounds suspiciously like angina pectoris, notice that your doctor will ask you a specific set of questions. He or she is mentally calculating your score. Here are a few scores. Quite appropriately, given the football context above, there is the ESC score, the European Society of Cardiology score, which is a score to help your doctor calculate your 10-year risk of developing cardiovascular heart disease, a heart attack or a stroke. The risk factors considered here are your age, your gender, your blood pressure, your smoking status, yes or no, your total cholesterol, and your non-LDL cholesterol, basically everything but the good cholesterol. The good cholesterol being known as HDL, high density lipoprotein. A specifically Swiss score is AGLA score, which in German is AGLA, Arbeitsgruppe Lipide und Atherosklerose. And this is the working group on cholesterol and atherosclerosis, which is basically the furring up of your arteries, specifically of the heart and the brain, leading to heart attack and stroke respectively. The AGLA score is shown here. Your doctor will ask you if you have someone in the family who has had a heart attack or a stroke, or if you yourself are a smoker. They will, of course, run some tests to check your cholesterol and sugar levels. If you want to go back in history, you will, of course, find the grandfather of cardiology scoring systems, the Framingham score, which arises from the great Framingham study of 1948 to identify risk factors for cardiovascular disease. Here is the scoring system of Framingham. If we want to look at a heart rhythm problem like atrial fibrillation, where the small chambers of the heart beat chaotically, and this can lead to heart failure and stroke as well eventually, the score for this is the EHRA score, EHRA, the European Heart Rhythm Association. Similarly, we have a CHADSVASC score to tell your physician how high your risk is for developing a stroke if you have atrial fibrillation. And here is the CHADSVASC score demonstrated or illustrated here. If we look at other specialties in medicine, we will find scores everywhere. Let's take dementia, for example. We have a mini mental state examination score to assess how bad a patient is affected by their dementia. And what about internal medicine? Let's look at sepsis, which is a good example, and actually a very interesting and personal one for me. I trained as a doctor in the UK and practiced there for a few years before continuing my work in Switzerland. I was used to assessing patients with sepsis just fine, without the need for a score. Then I went over to work in the UK a few years ago, and suddenly we had to apply a sepsis score when assessing any patient with sepsis, or come to think of it, with anything. We basically had to apply the sepsis score to all hospitalized patients, irrespective of their diagnosis. I researched the background to this and found out that in my absence from the UK, there had been a spate of misdiagnoses of patients with sepsis, and these misdiagnoses, based on us doctors missing very subtle signs of sepsis, had led to a high number of deaths within the NHS, being the National Health Service. There was in particular a high-profile case involving a pediatric patient, a child, which caused such a furore between the body of doctors in the UK and the General Medical Council, the GMC. I am sure the British among us will guess which case I'm referring to, but I prefer not to go into it here, as it is anyway a little bit off topic. The most common sepsis scores we have are the SOFA score, the SEERS score, and the NEWS score. Let's start with the SOFA score. What's a SOFA score? SOFA stands for Sequential Organ Failure Assessment, and it's a scoring system that assesses the performance of several organ systems in the body: the brain, the blood, the liver, the kidney, and the blood pressure, etc. The higher the SOFA score, the higher the likely mortality, death. Why was the SOFA score developed? It was simply developed because it was found that many patients were sadly losing their lives for the most banal things when admitted to hospital. SOFA is quite accurate when used in sepsis cases and when applied to other groups of patients. For example, if 100 severely ill septic patients requiring intensive care unit treatment have a SOFA score greater than 11, over 90% of them will die. And this is from a study by Vincent et al. From 1996. One benefit of SOFA is that it requires only 6 common points of data to calculate. Now let's look at the SEERS score. The SEERS, or Systemic Inflammatory Response System, SIRS, criteria represent a series of objective physical and laboratory findings indicative of an infectious or even non-infectious insult provoking a systemic immune response. The SEERS criteria are commonly used in the emergency department setting as a screening tool to identify rapidly septic patients or any patient who is basically going to deteriorate very fast. So it's a quick tool to enable doctors to basically save a life already in the emergency department before the patient gets admitted in the hospital. For NEWS, NEWS score, I shall let Professor Bryn Williams tell you all about it. Please watch the clip, which plays next.
NEWS, the National Early Warning Score. This was launched in 2012 and developed in response to a number of national inquiries into patient deaths in hospitals, and these identified the need for early detection to improve patient outcomes and the importance of having some sort of early warning score system. That's why we developed the NEWS. Now, it's national because it's important to have a single system that is standardized across the NHS, so that we're all speaking the same language, we're all using the same system for education and training, and we understand what it means when we move between organizations. The NEWS is simple. It's based on the 6 basic physiological parameters that we normally measure in hospital. That is pulse rate, blood pressure, respiratory rate, oxygen levels, temperature, and conscious level. When we become ill, these begin to vary, and it's the variation from the norm that we allocate a score to, which is very simple to record, and the aggregate of that score gives you a very accurate measure of illness severity. And we use that as a basis for triaging the response to patients. More recently, this year, we've updated the NEWS and introduced NEWS 2 with 3 new elements. The basic system is the same. We've simply enhanced it and improved it. And these are, we've added new confusion as a scoring parameter, because we know that when somebody becomes acutely confused when they're ill, this is a very powerful sign of clinical deterioration. We've improved the safety of oxygen prescribing by providing a dedicated chart for patients with type 2 respiratory failure and COPD. And importantly, we've recognized that a threshold score of 5 for NEWS in patients who might be septic because they have an infection or at risk of infection should make us all think, is this sepsis? If you have somebody at risk of sepsis with a score of 5, think, is this sepsis? We think this will greatly increase the early detection of sepsis, which is so important in improving the outcome of these patients. Now, who should be using NEWS? Well, basically anybody who's making measurements of these physiological parameters in the system. And for training, it's very easy. We've created a really good online training module which you can access from the Royal College of Physicians website, or simply by Googling the National Early Warning Score. You'll find it there. And it's a half-hour simple module after which you get accreditation in the NEWS. NEWS has now been endorsed by NHS England, the National Quality Board, NHS Improvement as the early warning score system for use across the system. In addition, NEWS is mandated for use in acute hospitals and by acute ambulance trusts. We'd like to see it used across the entire system, because we're already seeing early examples of where NEWS is used extensively. Reductions in hospital mortality, which are very significant, and also reductions in cardiac arrest rates. There seems little doubt, but the implementation of a national early warning score will make our hospitals safer, will detect acute illness deterioration faster, will respond faster, and improve the likelihood that our patients will survive from acute illness. That is the purpose of NEWS.
Correctly correlated with the high mortality rate, the sepsis issue was swiftly and drastically addressed, and now no inpatient in a UK hospital is without a sepsis score. This reminds me actually of the previous other time when I noticed the implementation of a scoring system quite suddenly, and that was with respect to pulmonary embolus or clot in the lung, especially in surgical patients, because the junior doctors who were assigned to look after these patients were more often than not forgetting to thin the blood of these patients, and they were dying of blood clots everywhere. Suddenly, a new chart appeared in all patient folders mandating perhaps that's a strong word, perhaps just gently reminding all doctors to think about anticoagulation, blood thinning for all patients stuck in bed for one reason or another. After childbirth, after major surgery, particularly cancer and orthopedic surgery, so hip replacement, fracture operations and such operations, and those who were just too ill to get out of bed, intensive care patients, etc. And now, all over the UK, nurses regularly police young doctors on this issue. That's a fact. I have lived through it, so I know. Now, this, I laugh, but this significantly improved outcomes for patients and continues to do so, as is shown here. So, this is all well and good, right? Then what's bugging me? Typical doctor, I'm never happy. Please hear me out, hear me out. My gripe may actually be the same concern some patients have, I think. My specific gripe is, does all of this scoring system make modern medicine too impersonal? This would certainly be the gripe of the generation of doctors currently at retirement age or close to retirement age. There is a protocol for everything. You can't use what is known as clinical judgment anymore. Where in the past, doctors used their training to sniff out a potential or actual crisis waiting to happen in a patient, nowadays you're not even allowed to. There's no creativity within medicine anymore. Everything is standardized to fit the general population and not this particular patient sitting in front of me or lying in a bed in front of me. No room for thinking outside of the box. No lateral thinking allowed. Everything is delivered to you on a platter in the guise of guidelines from on high. And if you deviate from said guidelines, you are hauled through the coals. Enough of the gripes of the older generation doctors. What about patients? What do they think? A side effect I can definitely spot with all these scores is that if a doctor is busy tallying up your score in his or her head as you tell him your symptoms or her your symptoms, there is very little room for personalizing your care. There is also less time to deal with other non-organic issues with your health. And your health includes your mental health issues, your psychosocial issues, etc. There is no time to partake in a little bit of small talk, which actually helps a doctor to deliver the best care to you. Once again, I note that modern medicine is perhaps becoming too impersonal. That should be probably the title of this video. Is modern medicine becoming too impersonal? But I thought, what's the score? Sounds better. Compared to the UK, Swiss medicine leaves much more room for maneuver in practicing medicine. But even Swiss doctors have a minimum of score-based medicine that they have to practice. In a Swiss general practice, a maximum of 20 minutes is allocated to each patient on average, and this has been mandated by specific cantons. This is the allocation in Bern, which is the canton I live and work in. I know that this is much less than in other countries. I am reliably informed, for example, that in Austria, it's more like 5 minutes per patient. I think that the doctor who told me this was probably exaggerating, but maybe not. Are there any Austrians here? Can you tell me your experience of your doctor appointments in general practice in Austria? Now, one thing that's been plaguing me for a while, I am always rather amused when I go to a restaurant and the waiters are so courteous, so polite, so hell-bent on making you feel good while you eat. They make sure you have a good time. You know how they hover around your table to find out if you're enjoying your meal? Some even chat to you a little bit and they explain the origin of the wine they pour out for you to taste. And they say, right away, ma'am, or right away, sir, when you ask for salt or extra bread or whatever. Now, I know they are basically pitching for your custom. They have to impress you. Maybe it's for the tip. Fair enough. But think about it. Do you get this kind of treatment in a normal public hospital? Okay, private hospital patients are not allowed to answer this question. But seriously, if medicine is a public service industry, like restaurants and eateries are, should we be a bit ashamed at the social treatment of patients, which is not really comparable to the social treatment of customers in other service industries, hotels, restaurants, even libraries and markets? Why this difference in treatment? Am I being too critical of my own profession? Is it nul point for modern medicine versus 9 out of 10, 8 out of 10 for the service industry a la Eurovision Song Contest scoring system? Now, that's another scoring system. I see scores everywhere. By the way, not bragging or anything, but in this year's Eurovision Song Contest, Switzerland won. And it was a person from the canton of Bern, where I live and work. Just thought I'd put that in. Seriously, is it scandalous that my hairdresser knows more about my medical history than my actual doctor? Granted, I spend more time at my hairdressers than at my doctor's. But still, is it fair to say that my hairdresser knows me much more intimately than my doctor? I think it is. In my case, it certainly is. But is this to be expected? Is this normal? Or does anyone else think this is unacceptable? What is your score for medicine versus the service industry? Has a scoring system in medicine saved your life? How would you rate your patient journey in a hospital or in a practice or simply your journey through a chronic illness? Care to share all this information? If yes, I would love to hear whatever you have to say on this matter. In any case, stay healthy. And if you have any questions, feel free to ask a doc.